Hello everyone, I am Dr. Singaram and welcome to the recall session in Pediatrics for the questions asked in the year 2022. I will start with INI CET May 2022 recall in Pediatrics. We will start with the first question, which is about neonatal resuscitation. In neonatal resuscitation, which of the following is the most effective indicator of successful ventilatory effort? Is it color change, rise in the heart rate, chest movement, or chest rise? The answer is rise in the heart rate. Remember, this is an important point that whenever you start assisted ventilation, which is nothing but positive pressure ventilation in a neonate, we always look for a response. Even though there will be change in the color, there will be increase in the chest movement and the baby starts improving, the first change which always occurs is increase in the heart rate. Please remember, increase in the heart rate to more than 100 per minute is considered as an effective indicator that the assisted ventilation is actually working in that particular child. Few points about positive pressure ventilation. The indication for PPV is after doing the initial steps of resuscitation. If the baby is not improving, you will check for the heart rate and the respiratory effort. If the heart rate is less than 100 beats per minute after the initial steps, it is an indication for starting positive pressure ventilation. And as I said, the response is increase in the heart rate to more than 100 per minute. That is the most sensitive indicator that positive pressure ventilation is actually working in that patient. Next, we know that positive pressure ventilation can be given by either bag and mask ventilation or by endotracheal intubation. The first step we always do in PPV is to start with bag and mask ventilation. However, there is one important contraindication for BMV, which is bag and mask ventilation. What is that? It is CDH or congenital diaphragmatic hernia. Because we know that once we give bag and mask in congenital diaphragmatic hernia, it would lead to distension of the intestines, which will cause more compression of the lungs and thereby cause worsening. So that is why in congenital diaphragmatic hernia, bag and mask ventilation is absolutely contraindicated. Another important question related to this bag and mask ventilation is, suppose you have started BMV and heart rate is not improving after bag and mask ventilation. What should be the next steps to be done? It is remembered famously as a mnemonic called MR SOPA, where M is you readjust or reposition the mask, repositioning of the mask. R is for readjustment of the head. The usual way in which head and neck is positioned is slight extension of the neck. Maybe if that is not followed, you will not get a response to bag and mask ventilation. So readjustment of the head position should be done. S is for suctioning. Maybe some secretions are blocking the mouth and nose, so you can put a suction catheter to take out those secretions. Then O is slightly open the mouth and then provide bag and mask ventilation. Then P for slightly increase the pressure at the time of giving bag and mask ventilation. Suppose you have tried everything and still bag and mask ventilation is not working and there is no response in the baby, then you have to finally go for A, which is the alternate airway. Alternate way is by putting an endotracheal tube, ET. These are the steps which should be followed in order whenever there is no response to bag and mask ventilation. Moving on to the next question. 11-month-old boy presents with recurrent blood in the stools, bloody stools, atopic dermatitis and petechiae. Investigation revealed a platelet count of 20,000 per cubic millimeter, which is obviously low platelet count. What is the next step to establish the diagnosis? You see here, there is some characteristic presentation in this particular child. What is that? There is recurrent bloody stools along with atopic dermatitis. Along with that petechiae is probably due to low platelet count or thrombocytopenia. The combination of this set of findings is very classical of Viscotylis syndrome. Viscotylis syndrome. Please remember, in the previous year's question which are asked about Viscotylis syndrome, they also give you about one more important finding, which is recurrent pneumonia or recurrent respiratory tract infection. That is also a characteristic feature of Viscotylis syndrome. Now the diagnosis is Viscotylis syndrome And the question is about what is the next step to establish the diagnosis. Is it screening for VASP gene expression, check for antiplatelet antibodies, bone marrow aspiration, LFT, and serum creatinine? Please remember, Viscotylis syndrome is characterized by abnormalities in the VASP gene. So that is why the answer for this question is to be, you have to detect the abnormalities in the VASP gene by gene studies. Okay, so the answer is option A. Antiplatelet antibodies are not implicated. It is not the cause of thrombocytopenia in them, so it is not an investigation. Bone marrow aspiration is generally not done as an initial step for Viscotylis syndrome, so that is also wrong. And LFT and serum creatinine are not related to Viscotylis syndrome presentations. So answer is option A. And few points about Viscotylis syndrome. It is inherited as a X-linked recessive condition. So males are going to be affected by this particular condition. And as I said before, the gene is VASP gene defect on the X chromosome. You can easily remember WAS or Viscotylis syndrome and P for the protein. So it is called as a VASP gene. Okay, it is self-explanatory. And talking about the immunoglobulin profile, these patients have low levels of immunoglobulin M, IgM, elevated levels of IgA as well as IgE, and they usually have normal or slightly low IgG. These are the characteristic immunoglobulin profile noted in a patient with Viscotylis syndrome. Next is about the treatment. It is going to be bone marrow transplantation. These are the salient points about Viscotylis syndrome. Moving on to the next question. What is the best alternative to mother's breast milk in a low birth weight baby? Is it preterm formula milk, cow milk, donor milk, or term formula milk? Please remember, there are a lot of questions nowadays asked about a care of a preterm baby or low birth weight baby. This is more related to feeding of a preterm or a low birth weight baby, as well as problems encountered in preterm or low birth weight baby. This particular question is taken from AIMS guidelines related to management of low birth weight infants with respect to feeding. Can you see that? All low birth weight infants, irrespective of the initial feeding, should receive only breast milk. This is very, very important. You can provide pallidi feeds or gastric tube, that means nasogastric or orogastric tube feeds. However, it should only be with the help of expressed breast milk. The best, of course, is always mother's own breast milk. If not available, the alternative is human donor milk. That is what is the guidelines say. In this question, it is saying that alternative to mother's breast milk. So what should be the answer? Answer is donor milk. That is what you should remember. Generally remember, this human donor milk is procured from human milk banking facilities. That is how this human donor milk is procured and can be given for the babies as an alternative for mother's own breast milk. Now talking about mode of feeding in preterm babies, it depends on the gestational age of the baby. If a baby is less than 32 weeks of gestation, usually it is the nasogastric tube feeds, that is NG tube, or orogastric tube feeds is given. If the baby is between 32 to 34 weeks of gestation, it is given by pallidi feeds. The expressed breast milk has to be given by pallidi feeds or katori spoon feeds. And if the baby is more than 34 weeks of gestation, direct breastfeeds are indicated. Another additional point to be noted is, if the baby is less than 28 weeks of gestation, the baby's gastrointestinal tract is not suited for breast milk in the sense that the absorption and digestion may not be very, very proper. So for a baby less than 28 weeks of gestation, enteral feeding with breast milk is not indicated. Instead, it is TPN or total parental nutrition is what is indicated. So that's about this particular question. Moving on to the next question. Again, a repeat question. ACTH is the drug of choice in which of the following situation? JME, which is juvenile myoclonic epilepsy, Rolandic epilepsy, West syndrome, infantile spasm, or Lennox-Gastaut syndrome. What is the answer? It's a straightforward answer. ACTH is the drug of choice. It is given as injections for West syndrome or infantile spasm. Okay. Remember, for juvenile myoclonic epilepsy, the drug of choice is sodium valproate. Rolandic epilepsy is a condition characterized by recurrent focal seizures for which the drug of choice is carbamazepine. Nowadays we know oxcarbamazepine is what is used. Lennox-Gastaut syndrome, please remember, I cannot single out one particular drug because even though valproate is most often used in the management, it is a condition characterized by multiple refractory seizures. So the management with the usual anti-epileptic medication is not very satisfactory. Okay, so now the answer is clear. It is West syndrome or infantile spasm. Now talking about West syndrome, it's a condition characterized by a triad. The first in the triad is infantile spasm. As the name suggests, infantile. So the onset of this condition is in a child less than 1 year of age. Spasms involved the limbs characterized by jerky movements in the limb called as the jackknife seizures. It can also be associated with spasms of the neck flexors, okay, which is called as the salam spells. That is the first in the triad. Next is a characteristic EEG finding called hypserythma. I will describe it shortly. And third is intellectual disability or low IQ. Now this is a characteristic EEG finding which I was talking about as hypserythma. You can see that the tracing is very haphazard. So this background itself is very irregular or chaotic, and on top of it you are seeing some big high voltage spikes which represent the seizure activity. So the classical description of the hypserythma is high voltage spikes in a chaotic background. High voltage spikes in a chaotic background, that is actually called as a hypserythma, a very classical EEG finding in case of West syndrome. Please remember, the drug of choice or the treatment of choice is injection ACTH. That is what the question was asking about. The second line drug is called as vigabatrin. However, an important point to be noted is there is a neurocutaneous syndrome called tuberous sclerosis. That condition can also be associated with West syndrome. However, a point to be noted is if tuberous sclerosis is associated with West syndrome, the first line drug now becomes vigabatrin. So general case, it is ACTH, which is the first line drug, but tuberous sclerosis associated West syndrome, it is vigabatrin, which is the first line medication. The next question, congenital absence of vas deferens and seminal vesicle is noted in which of the following? Cystic fibrosis, Klinefelter syndrome, Kalman syndrome, and testicular feminizing syndrome. The answer is a straightforward one. It is very characteristic association of cystic fibrosis. Now remember, cystic fibrosis is like almost a sure question in any of the competitive exam asked nowadays. So many questions have been asked in the past, and so I want you to study the topic in detail, okay, about cystic fibrosis. Now talking about the other condition, Klinefelter syndrome is not an answer because it is not associated with the absence of vas deferens in seminal vesicle. Instead, it is associated with cryptorchidism as an association. Kalman syndrome is associated with delayed puberty as well as anosmia. Testicular feminization syndrome or the androgen insensitivity syndrome is a condition characterized by resistance to the action of testosterone and not absence of vas deferens in seminal vesicles. Okay, so now this is a line about cystic fibrosis and this question given in Nelson textbook of Pediatrics, which says very clearly virtually all males are azoospermic because of the failure of development of the Wolffian duct structures, but the sexual function is generally impaired. And because of azoospermia, there is infertility. So almost all affected males with this condition are infertile due to azoospermia. And because of that absence of the Wolffian duct structures. Now these Wolffian duct structures absence includes atresia of the body and tail of the epididymis, as well as vas deferens, as well as seminal vesicles. Okay, so all the Wolffian duct structures are getting affected, resulting in azoospermia and associated infertility. Regarding the females, females do not have much of a problem. However, it is clearly mentioned that fertility rate is decreased in case of females, especially those who have poor nutrition or advanced lung disease. So these are the points related to the cystic fibrosis in association with infertility in males and decreased fertility in females. Next question is about partial aneuploidy seen in which of the condition? CAH is an autosomal recessive disorder, so that is not the answer. Congenital adrenal hyperplasia. Vagar syndrome is not at all an inherited condition. It is something related to a deletion of genes in the chromosome number 11. That is not the answer. TF syndrome or testicular feminization syndrome again is not related to aneuploidies. So what is the answer for the question? It is Cry-Du-Chat syndrome. Cry-Du-Chat syndrome is a partial aneuploidy. It is characterized by a partial deletion or monosomy in the chromosome 5p, which is short arm of the chromosome number 5. Now, Cry-Du-Chat syndrome gets its name from the characteristic high-pitched cry or a cat-like cry noted in these babies. And other associated findings include microcephaly and hypotonia, and they have low IQ. There is also a characteristic set of abnormalities noted in the face, which include widely separated eyes or the hypertelorism. You have low set ears as well as small jaw appearance. All these are characteristic facial abnormalities noted in a child with Cry-Du-Chat syndrome. But the commonly asked questions you should remember, partial aneuploidy in chromosome number 5p as well as high-pitched cry or the cat-like cry. Okay, right. Next question. A 4-year-old male child with a body weight of 15 kg and height of 100 cm is admitted with renal failure. His blood urea was 100 mg per deciliter and serum creatinine was 1 mg per deciliter. What is the closest calculated eGFR in this patient? That is what is the question. Is it 33 ml per minute per meter square or 40, 50, 80? See, this is a calculation based question and this is not a new question. This has been asked previously in the exams also. Now, the formula for calculation of eGFR, which is nothing but estimated glomerular filtration rate in children with the creatinine values, is something called as a Schwartz formula. Please remember the original Schwartz formula is like this, K into height by serum creatinine. But here the K value is a constant. You can see the values of the constant are given by the side. It is very, very variable depending on whether it's a preterm or a term, and again whether it's a infant or a older child. You can see so many values are given like 0.34, 0.45, 0.55 like that. However, with the revision of Schwartz formula which came in 2009, and that is what we are using, there is one fixed value of K nowadays being used. What is that fixed value of K? It is 0.143. This is the fixed value of K which I want you to remember. Okay, that is the change which has been made in the revised Schwartz formula, but other things are the same. It is constant into height expressed in centimeters. Remember, this is important. Height expressed in centimeters divided by serum creatinine in milligrams per deciliter. Now, putting up this formula in the question which was asked, it is 0.413, that is a constant value, into height. What is the height of this child? It is 100 centimeters into 100 divided by serum creatinine. What is the serum creatinine? It is 1 milligram per deciliter. So divided by 1. So 0.413 into 100, it is roughly 41.3. Okay, right? So which is the closest value among the given option? It is option B. You can see that it is 40 ml per minute per 1.73 meter square, which is the body surface area. So the answer has to be option B in this particular child according to the values given in the question. Moving on to the next question. A 7-year-old male presents with the fatigue, muscle and joint pain for the past few months. On examination, the following rash as given in the picture is noted. What is a possible diagnosis? Remember, fatigability, muscle pain and joint pain are not very specific. It can be a differential for so many conditions. Then what will make you think about the diagnosis in this particular patient is a characteristic rash which is noted. What is that? You can see that there is a rash in these areas on the back side of the fingers, or the dorsum of the fingers, at this MCP areas, metacarpophalangeal joint areas, and also the skin over the interphalangeal joint also, interphalangeal joints, okay? And it is classically described as this red colored scaly lesions in the skin over the dorsal aspect of the joints, namely the metacarpophalangeal joint and the interphalangeal joint. What is the name of this rash? It is typically called as the Gottron's papules. And the presence of Gottron papule in this child pins the diagnosis as Juvenile Dermatomyositis or JDM, Juvenile Dermatomyositis. In fact, remember, I am going to tell you about the criteria of juvenile dermatomyositis. In that criteria, you will notice that presence of the characteristic rash is essential for diagnosis. Okay. One, they can give you the Gottron's papule, or there is also another type of rash which is noted in juvenile dermatomyositis, which goes by the name of Heliotrope rash. Heliotrope rash. Now, this heliotrope rash is a bluish violet rash noted in the periorbital area. Okay, and it is also associated with edema in the periorbital region. Okay, that is another characteristic rash called as the heliotrope rash. In some of the questions, this is also given. So please remember, because of the presence of the rash in this particular child only, I made the diagnosis of juvenile dermatomyositis. This is the diagnostic criteria of juvenile dermatomyositis, where you can see the essential criteria is the rash. Very, very important. It could either be the heliotrope rash or the Gottron's papule. That is a must. Along with that, 3 of the following should be present. Number 1, it could be muscle weakness. Generally remember, it is proximal muscle weakness. And also remember, due to proximal muscle weakness, even Gover's sign can be positive as well. Remember, you must have studied Gover's sign positivity in another proximal muscle weakness disorder, which is Duchenne muscular dystrophy. It can be positive in this condition as well. That should be remembered. Number 2 additional feature is muscle enzyme elevation. You can see the different muscle enzyme elevation I have given by the side. It could be creatinine kinase, aspartate transaminase, LDH or aldolase, but the commonly elevated one is a creatinine kinase, which we usually do as an investigation. Number 3 is muscle biopsy finding. Okay, and number 4 is EMG, which is electromyogram changes. I have listed the electromyogram changes in a small box in the side, where you can see fibrillation, positive sharp waves, or small motor unit potential. It is not absolutely necessary that you should know all the EMG changes, but at least you should remember that EMG changes can also be an associated finding, which will point to the diagnosis of juvenile dermatomyositis. So again, quickly revise, it is rash plus 3 of the following in the muscle involvement should be present. Okay, so that is a diagnostic criteria for juvenile dermatomyositis. In this question, it is very clearly given. There is muscle pain, joint pain. Along with that, there is a Gottron's papule also. The diagnosis is juvenile dermatomyositis. So that is about the discussion of INI CET May 2020 questions asked in the section of pediatrics.